Did you know that 1 in 8 women will be diagnosed with breast cancer at some point in their lives? And early diagnosis saves lives. On this week's Health Talk, we will discuss breast cancer screening and diagnosis with an expert in the field. She's Dr. Susan Boolbol, Chief of Breast Surgical Oncology and the Breast Program at Nuvance Health. Stay tuned, Health Talk is up next. Hello, I'm Dr. Eric Mazer. On this week's Health Talk, we are discussing breast cancer screening and the importance of the early breast cancer detection. Our guest, Dr. Susan Boolbol, Chief of Breast Surgical Oncology and the Breast Program at Nuvance Health. Susan, welcome to Health Talk. It's good to have you back.
Yes.
I was so impressed the first time we met. I'm glad that you're still active and here. That's just wonderful.
I am. I'm impressed every time you do this. I mean, you just get the word out and educate people every day.
It's such a
about
wonderful
these
opportunity to speak to patients
Right.
over a large scale.
Yeah, it really is great.
There's so much out there about breast cancer screening. I think women know about mammography. Why don't you sort of go through, if you would, sort of the general recommendations, but more, and then go into why doesn't everybody follow them?
Right. I mean, we do wonder about that because we think that the word is out there, but I'm not so sure that it is. I mean, people are busy in their lives. They're not really thinking about, oh, I need to go get my mammogram. So the recommendation for average risk women is to start yearly screening mammograms at 40 years old and then every year after that. Not really every 2 years or every 3 years, but ideal is every year.
And that's changed a little, hasn't it? It's become a little bit earlier.
Well, you know, the recommendations, depending on who you listen to, changes. So years ago, it was 40 and up every year. And then the U.S. Task Force, the U.S. Prevention Task Force, which I think is a bit of a misnomer because they keep decreasing screening, said let's start at 50. And it was very interesting. They had this in-depth study that all looked at the same studies, and they concluded that mammograms save lives. 100% without a doubt, mammograms save lives. But at what cost? It's very anxiety-provoking for women. They use this as a reason to change what year women start at, from 40 years old to 50 years old. That anxiety was one of the reasons. I don't know. I think women can handle a lot of anxiety.
I'd rather be anxious than have cancer any day of the year.
And let us all determine what degree of anxiety we can handle. So we recommend all the overseeing bodies of breast cancer really in this country recommend 40 years old and yearly after that. Now that's a bit different than other countries. Many other countries recommend every 2 years. And the real reason that they do that is because overall, breast cancer is slow growing. And the feeling is, oh, you know what, we'll catch it the next year. Well, in the US, we're a little more progressive than that, and we want to catch it as early as possible.
Because catching it earlier, it's smaller, and therapy may be more limited.
We know that early detection saves lives. And it changes treatment, as you just said.
And we know that unequivocally. With some screening, there's arguing, but we should say there's no question. We know mammograms save lives by detecting cancer earlier where it's more curable.
Right. Now, mammograms don't prevent getting breast cancer. Their goal is to detect it. And when they detect it, it works.
Right, so it's not a failure if you have a mammogram and it's positive.
Right, and I have patients who come in and say, I get my mammogram every year. How did I get breast cancer? Well, it did its job. You have the earliest stage breast cancer that we can diagnose. Your mammograms worked. That's why we do it.
And let me, before we leave, you said for the average risk person. For people at home, when are they average risk, or when do they have a more, are they in a more risky situation, if you will?
So as you mentioned in the opening, average risk is 1 in 8. About 12%. That's pretty high. Yeah. I mean, when you think about it, think about other cancers, say ovarian cancer. Average risk is 1% or less. The only cancer that's higher probably is skin cancer, you know, your basal cell skin cancer. But it's a really high risk to start out with. So the main risk factors we really cannot control: being a woman, getting older, and family history. But family history is only significant if you have one. If you don't have a family history, guess what? you're back at average risk, which is 1 in 8.
You mean by don't have one, you mean you don't have a family member who's had breast cancer?
Correct. So if you do not have a family history of breast cancer, you're still average risk. Having a family history can increase your risk, which is why it's important that when you're going to your primary care doctor or your gynecologist, that you go through your family history of different cancers.
How close a family relationship do you need for it to add to risk?
So that's a great question, because it's not just how close the relatives are, but at what age.
Very important
So
point.
if your grandmother had breast cancer at 30 years old, that's very different than if your grandmother had breast cancer at 90 years old. And the other important piece of information which people get confused with is that your father's family history is just as important as your mom's family history for breast cancer. And women naturally think, oh, just my mom's family history matters. No, both, because you get 50% of your genes from your dad, 50% from your mom. We just don't know what the mix is. So very important to know both sides of the family.
And to consider that, yeah.
Right, and the
Yeah,
other
that's
issue,
in general true. If you have
General.
early cancers in your family,
right,
on
It's
either
much more
side, you
significant.
worry about a genetic component.
correct, correct.
And where do we throw that age? At 50 or below?
It is less than 50.
Okay.
But the other thing to look at is you may not have a lot of women in your family. So your mom or your dad might not have any sisters. So then the next closest relative is your grandparents' generation. So it varies depending, compared to if your mom has breast cancer, but she's one of 9 and she has 6 sisters with no history. Well, then we're worried less. So it's really the big picture. We cannot
If a
say
male had breast cancer, you want to mention that?
always significant.
Yeah.
Whether it's a first-degree relative, male that had it, or a first cousin.
Yeah, men do get breast cancer.
1% of all breast cancer diagnoses are in men.
And they
So it's
almost
very
all have a genetic predisposition.
No, not necessarily.
Okay.
I mean, it's easier when they do, because then we know why. So when they don't, then we worry. Like, why do they have it? Is it a genetic mutation that we just don't know about yet? And we know they're out there.
That dovetails with another question I have, and I'm sorry to keep.
No.
But
There's so much to talk about in breast.
It really has become
is.
an amazing field. How about other cancers and your risk of breast cancer? Other cancers in your family, or
Right.
yourself for that matter?
So very important that we don't just focus. So when a patient comes into a breast surgeon's office, you don't want to just focus on what's your family history of breast cancer, because there are many other cancers that can be related. Ovarian cancer and breast cancer are like sisters. They travel in the same families. So if we see a family with a history of ovarian cancer and breast cancer, next step is talk about genetic testing with them, because that's very concerning family history. But also we want to take into account colon cancer and pancreatic cancer and even melanoma. They can all travel
know about melanoma.
yeah,
I knew about
on the
other
same genes as breast cancer if you have a genetic mutation. There's many other cancers that can. If you have a strong family history of gastric cancer, we definitely want to do genetic testing on you. Not as much for the breast cancer, but for the gastric
I think
cancer.
I don't want to divert too far, but I think that's such an important point. Today, we're understanding a lot of the genetic predispositions in a way we didn't even 10 years ago.
Correct.
And genetic testing, and this doesn't necessarily mean the 23andMe or the one.
No.
We're talking
But
about
that's a
medical
good point
testing.
that you brought up.
Yeah, talk about that.
Because patients come in all the time and say, oh, I don't need genetic testing. I did it with 23andMe and I don't have a genetic mutation. That is a dangerous myth. So 23andMe, you can test for the BRCA1 and 2 gene, but it's only testing for what we call the founder mutations. So Ashkenazi Jewish, 5 mutations. They're the most common mutations in Ashkenazi Jewish descent. But that's not the average person.
Yeah.
So you can test and it's meaningless for you. So it's a big myth that, oh, I did that so I'm clean. don't believe that at all.
Without getting into the laboratory science of it, what they're doing is just saying, do you have this mutation or not? They're not really looking at the genome and saying what mutations are there.
Without a doubt. And the other potential genetic mutations.
So that's really important.
Right.
So then let's talk a little bit of screening. What's new in mammograms? Mammograms have been around forever. Women tell me they're horribly uncomfortable. And people worry about the radiation exposure. What's happening?
So many topics to cover on that.
Yeah.
Let's talk about
we have 4 minutes.
what you said, that the pain. So they've done studies on this because women complain about the pain all the time. Listen, I get mammograms. They're not the most comfortable thing in the world, but so worth it to diagnose breast cancer early. So they've done studies comparing the pain, all these pain scales that we have. And it usually turns out to be a 2 to 3, which is that of a mild headache, if you're looking to compare. So I'm not saying that they're comfortable. None of us want. It's cold. The best comparison that I've seen is that two women are talking and they say, oh, I'm having a mammogram tomorrow. What's it like? And they say, take your shirt off, open up the freezer, put your breast in, and close the door really hard. So, but it's completely bearable, not bad, and it lasts for seconds. It's really very short. So that's one thing. The second thing is radiation, that women talk about, oh, I don't want the radiation exposure, it's very dangerous. The American Cancer Society years ago, and mammograms now have less radiation than when they did this. The radiation you get from a mammogram is less than the radiation you get flying from New York to California. So really not even measurable amounts of radiation. So that's not a good reason not to have your mammogram. And then what's new in mammograms? And it's changed so much. I mean, I look at the mammograms from even early 2000s, and it's amazing that the radiologists could find breast cancer in them because it's so vastly different now. So it really has evolved to this.
This is really the technology.
The technology
and the
has
pictures
evolved.
are better.
It's unbelievable. So it's like looking at a proof of a picture from 40 years ago compared to the highest quality digital imaging that we have now. So the first change was we went from film to digital, and that was done 20 years ago or in that range. Now, and it was 2D, meaning you had a picture, 2 pictures of each breast, one this way, one that way, and that was it. Now we have 3D mammograms, which really take slices of the breast as they go through the breast. So the breast imager,
we have 1 minute left.
The breast imager or the radiologist, when they're looking and interpreting the mammogram, they're looking at different slices throughout the mammogram as opposed to one picture. That's called 3D mammogram. Whenever a woman goes in or a man to get their mammogram, that should be the first question they ask. Is it 3D?
Because that's a really important point. So the standard of care now, the standard of screening, 3D mammogram, ask about it. People will know what you're talking about.
And everywhere, at all of our sites at Nuvance, we only have 3D imaging. We don't offer
There's
anything.
still other 2D imaging out there?
Yeah, unfortunately
so people
there is.
should shop.
You have to ask.
Okay, that's really an important and very useful thing. Again, we have just a few seconds left, but how about the interpretation? I read about computerized assistants and that they're picking up things the radiologists are missing. Is that in use right now?
It is.
Will it be in the future?
Oh, I think that it will be even more so. So computer-aided detection has been in for years and years and years, and it assists the radiologist. AI will maybe replace the radiologist read in some situations, but that field is growing and growing, not necessarily out for prime time yet, but it will be in the next few years.
So our accuracy is getting better and better. Are we seeing improvement in the early diagnosis of breast cancer with these better technology?
Yes, that's what I was going to say. Better technology leads to earlier diagnosis and fewer callbacks.
And so we're actually seeing breast cancer mortality continue to fall.
2% a year, every year since the 90s.
This is great news. A common cancer that we're making significant inroads, and we've run out of time. So thank you very much. I want to thank Dr. Boolbol for joining us today, and thank you for watching. Please share your comments and questions with us by emailing us at healthtalk@nuvancehealth.org. We'd love to hear from you. We'll see you next week on Health Talk.
$145 over 92. 180 over 111.
182 over 100. And I had a heart attack and a cardiac arrest, and then a stroke.
Your blood pressure numbers could change your life.
A lot of people don't understand, including myself, I didn't, now I do, the impact of having a stroke.
My memory is shot.
When I woke up, I couldn't speak.
If I would have followed a treatment plan, I would not be in this situation.
It's a tough journey.
Lowering your high blood pressure could save you from a heart attack or stroke. If you've stopped your treatment plan, restart it or talk to your doctor about creating one that works better for you. Start taking the right steps at manageyourbp.org.
It's a new life, but I'm gonna make it better. I'm coming back. Ask your doctor, check your blood pressure.
The past decade has seen dramatic advances in breast cancer. The breast cancer treatment are improving cosmesis, increasing cures, and prolonging survival. Today on Health Talk, we'll highlight some of these new breast cancer treatments with Dr. Susan Boolbol. She is the Chief of Breast Surgical Oncology and the Breast Program at Nuvance Health. Stay tuned, an exciting Health Talk is up next. Hello, I'm Dr. Eric Mazer. On this week's Health Talk, we are discussing recent and exciting advancements in breast cancer treatments. Our guest is Dr. Susan Boolbol. She's Chief of the Breast Surgical Oncology and Breast Program at Nuvance Health. Welcome back to Health Talk, Susan. It's so good to have you here.
Thank you so much, Eric. It's great to
You're right. It's such an exciting area. I mean, from every respect, there's so much going on. I don't even know what do you think are some of the more exciting advances over the last 5 or 10 years in the treatment of breast cancer?
You know, I think a major advance is genomic testing. So it used to be that every woman with cancer, with an invasive cancer greater than 1 centimeter in size, which is about a ½ inch, got chemotherapy right off the bat. Because that's all we knew.
That's what I did.
Right?
That's what I did for my career.
Every woman. Now we do genomic testing, and probably about 40% fewer women need chemotherapy for their breast cancer, because we now have a better way to figure out, will you benefit from it? And if you're not going to benefit, why are we giving it to you?
So 2 questions. Are you doing this genomic testing on the tumor itself?
Yes.
So the tumor, and maybe we should say that for people at home, what makes cancer are genetic changes in the cells that lead them to go from normal to cancerous.
Correct.
And we could actually detect those changes now.
Right, so this is really the era of personalized medicine. We're no longer treating populations all the same. It's no longer one size fits all. So now we can test the individual tumors. There's companies in our country that do this. We take some of the tumor, we send it to the company.
At the time of surgery, you take a piece of the tumor?
Well, no, it's actually done by the pathologist afterwards. And then it's analyzed, and we know the right treatment for the right patient.
And so what you're saying is that of that early stage breast cancer, 40% really have no risk of having metastasized by that time.
Well, it's that they won't benefit from chemotherapy. They need other treatments.
Okay.
And usually it's endocrine treatment, something that the audience might have heard of, tamoxifen or drugs such as that.
So I didn't realize that. So that we're able to stratify patients.
Yes.
That way.
Without a
So
doubt.
has this become now every tumor gets genetically evaluated, or is it just in the early stage?
It's more so the earlier stages, but we can say now, if you have an estrogen receptor sensitive cancer, which is the more common type of cancer, and you're still getting your period, and you have a lymph node that the cancer has traveled to, we know you will benefit from chemotherapy. As opposed to if you're in menopause, and meaning you've gone a year without your period, you have an estrogen receptor positive breast cancer, and it has traveled to the lymph node, chances are you will not benefit from chemotherapy. So in those cases, we'll go and get one of those genomic assays to tell us. And usually the majority of women do not need chemotherapy.
Well, so that must be
It's
a relief for the
unbelievable.
patients.
Unbelievable change in how we treat breast cancer.
So again, in my era, 20 years ago, perhaps, I'd say maybe 80%, 90% of women got adjuvant chemotherapy in one
Correct.
form or another.
Right.
Where does that total figure stand now?
So it's interesting. If we look at the most common type of breast cancer right now, which is estrogen receptor positive, HER2 negative breast cancer, and lymph node negative, because we diagnosed cancers earlier, only 15% of women in that category will need chemotherapy, because only 15% will benefit from chemotherapy. So that's drastically different from when you were treating
very
patients.
different. And I know even the regimens have changed somewhat
Yep.
to make it a little bit easier.
Right, and the medication to control the side effects has improved. I
'Cause
mean,
I remember when I was started, we would treat women for up to 2 years with adjuvant therapy. Now it's down to 6 months or something?
Yeah, at most usually. But when you look at one of the side effects, which is emotionally devastating to women, losing their hair.
Absolutely.
We now have ways to help control that. Doesn't work 100% of the time, but it works more than 50% of the time.
Again, I think people, that used to be something I'd say to patients, is you may not think you care, but it's going to be awful.
Yeah, it is. I say,
as part of not trying to depress them, but just saying, I've seen that over and over again. It was emotionally devastating.
Right.
I think particularly for women. Men, especially in this year, you can shave your
Right.
head and look fine. For women, it's emotionally devastating.
It is. And I don't think it's to scare them, just as you said. I think it's all about setting expectations, and I think that's our job as physicians. Gone are the days of paternalistic medicine.
Absolutely.
Where everything was sugar-coated. Oh, you'll be okay, and we know that the outcome may not be so good. So there shouldn't be any sugar-coating. It should be straightforward in a very caring manner. But it's all about setting expectations for the patients.
I look at the patients. Patients are our partners. We're doing everything we can, obviously, to help them. But if they've got to believe what we're saying, and if I tell them, "Don't worry about it," and then their hair falls out and they're devastated, and I remember story after story of patients telling me they started to see tufts of hair on the pillow.
It's
and
devastating.
it would be that would be emotionally.
Right.
That's when it sunk in.
Right. And it's interesting. I say to patients, next to being told you have breast cancer, the most emotionally devastating thing is losing your hair. And we know it's temporary, but it's just, you can't help but see now what's happening to your body.
It's walking around with a neon sign on saying, "I have cancer." And I think it's
very difficult.
It's awful.
It's very difficult.
How about the other thing that there was changing, and I don't know whether there's anything new in this area, is the cosmetic effects of the breast cancer surgery itself.
Yeah.
Again, in medical school, they did what was called the Halstead radical mastectomy, and you're smiling, but Dr. Halstead was at my institution, but they would take the lymph nodes out, the breast would be taken off, the muscle under the breast would be taken off. It created a deformity, and the armpit was absolutely cleaned out. It was almost like the skin was then stuck down to the bone.
It was stuck down to the bone.
All the way around here.
Right, so for women who had that surgery on the left side, you would literally just see their heart beating, because there wasn't much between the heart and their skin.
Right, just the skin was covered.
And sometimes they took all the skin and they needed skin grafts. I mean, it was awful, but it was the best they knew at the time.
Right, it wasn't people being mean. The theory there was, this allows us to get every last bit of cancer in the area.
And guess what? Women still recurred, so we know it did not get that.
And what that means is just that little pieces of the tumor broke off and traveled through the bloodstream or the lymph system and set up housekeeping elsewhere in the body.
Exactly, or even in the same place.
Yeah.
I mean, it goes to show that surgery does a lot of good, but we need other treatments to help us. So our viewpoint in surgery now is less is more. So we really try to do less and less and less as far as surgery and removing parts of the body and disfiguring the body. So oncoplastic surgery, combining onco, cancer, and plastic reconstructive into the surgery for breast cancer, really is, in my practice, mainstream. I do it for every patient and teach courses throughout the country. So hopefully more and more breast surgeons will be doing this.
So this is a step beyond just lumpectomy.
Oh, yeah.
It's lumpectomy plus reconstruction.
Right. So when
patients won't come out of the OR reconstructed?
Yeah, and it's just moving tissue around frequently, because when you think of a lumpectomy, what we are doing is removing the tissue that contains the cancer. But breast tissue does not grow back. So you leave a hole in the breast. And what happens is you get a divot in that area. And then with lumpectomies, women get radiation. And then radiation contracts it in a little bit, and you get more of a divot. And what happens with that is every single day, that woman thinks about breast cancer. 6 months from the surgery, a year, 5 years, 10 years, 20 years out, because she sees it every day. It is a constant reminder, as opposed to doing oncoplastic surgery, where we just move tissue around to fill in that area. And as I say, the goal is to maintain the shape and the contour of the breast. And in addition to that, we use a hidden scar technique so that the scar is not across the center of the breast. I mean, who wants to see that? It's not, we don't need to do that anymore. And therefore, the woman, breast cancer goes further and further and further back and hopefully becomes a distant memory. Now, when they come into the office for their mammograms or for their checkups, they always think about it, without a doubt. And they say, you know, it used to be I thought about it for a month, then I thought about it for a week. Now I think about it the night before I come in. That's where we want them. We want them to get back to their life and be a better version of themselves, because along with a cancer diagnosis comes perspective. And you really
so many people talk about that.
They do.
I mean, that's an odd paradox of oncology, is people often feel that it puts them in touch with what's important in life.
And they're a better version of them. I've had patients
hear that all the time.
Right, I look back, I didn't like who I was. I wasn't living the best me, and now I am, because it does bring perspective.
So just to, oncoplastic surgery should probably be part of virtually all breast cancer operations?
I believe it should. So even for women with larger breast and they have a larger cancer, we can do a lumpectomy on them. Whereas years ago we would say, oh, it's a larger cancer, you need a mastectomy. We can do a lumpectomy and a reduction on both breasts at the same time. We just involve our plastic surgery colleagues. And that is life-altering for the patient. So we do fewer mastectomies.
That's really wonderful to hear. And do people, again, I've always exposed my age, after lumpectomy or after even oncoplastic surgery, there's still that risk, that local risk of recurrence. Do they still get radiation to that breast?
They do. So radiation's recommended for, women under 70, women over 70. There's studies that based on their disease, the stage of the disease, the grade of the disease, whether they can forego radiation, skip radiation, and still have the same outcome. So that's really, again, goes back to personalized medicine, which is the era that we're in.
And there have also been, and we have like 60 seconds left, a profusion of new drugs and new ways to treat breast cancer. Can you just briefly, not necessarily naming every drug, but how has that changed?
It's a game changer. We have more oral chemotherapy, meaning you can take a pill, you don't have to go in and get an infusion through an IV. We have more targeted treatments. So if we have a target, rather than giving chemotherapy to treat every cancer
target based on the genetic analysis of the tumor.
Exactly, and that's such a difference. Based on the biology of the cancer, based on the genetics and the genomics of the cancer, we can target with different drugs that defect or that area that we're going after. It really is a game changer.
So with all of this, we're detecting earlier, we're curing more people. Do you have any sense of where the contributions are? Are they due mainly to earlier detection, or is the therapy also getting so much better that we're curing people that might not have been cured in the past?
I think it's a combination. I think that breast cancer, treatment of breast cancer and diagnosis of breast cancer is a team effort, and we need all the different teams. We need the breast imagers or radiologists, the surgeons, the medical oncologists, the radiation oncologists, and we make advances in every single one of these disciplines, which all benefit the patient.
We've run out of time, but it's breathtaking in a very positive way.
It's
not
just
that anybody,
exciting times.
It really is an amazing time in oncology. I think it's one of the most underreported stories internationally, is that we're making so much progress, but it's incremental, and so people don't really understand it.
Well, people don't think that 2% is a lot, but 2% every year, fewer deaths since the 90s.
Amazing. That's all we have time for. I'm so sorry, Susan, that we have to quit. I want to thank Dr. Susan Boolbol for joining us on Health Talk today, and thank you for watching. Please share your ideas, your comments, and your questions with us by emailing us at healthtalk@newvancehealth.org. We'd love to hear from you, hear about your questions and suggestions. We'll see you next time on Health Talk.